Yes, we've titled this discussion, Why Your Penis is Not Working. I'm sure we all have an idea of what we meant when we say your penis is not working. Definitely not for passing urine, it's for sexual function. We're talking about the sexual function. I'll use this outline to make the discussion a bit focused and um, more enlightening. So I'll define erectile dysfunction as the inability to get or keep an erection for satisfactory sexual activity. Now, this has three components. Is the patient or the person able to have quality erection? Is this erection able to, is the patient able to sustain this erection and also have satisfaction from the sexual activity? But occasionally, it will also be a regular thing. However, it becomes, you need to see a urologist if this is persisting for up to 6 months. What is the erection? The erection is just, again, we call that tubuces. What and how does it come about? There's the anatomical and the physiological aspect of an erection. The penis is the organ which gets erect once there's sexual arousal. It's composed of at least 3 erectile tissues. And I'll try to demonstrate, I'm trying to demonstrate that on the slides, if you see that. So the cursor is on the two, what we call the corporal cavernosa. They are the main erectile tissues. They are they're spongy tissues that fill up with blood once sexual arousal, once there's sexual arousal and cause erection. The third one, which is down below, is the corpus spongiosum. It also fills up, but because it is not surrounded by a thick, thin fascia called the tunica albuginea, once blood fills into this other two, the pressure in them becomes very high and they become very turgid. However, this third one doesn't have that same complete covering of the albuginea, and there are some struts that connect from one side of the albuginea to the other. Those are not visible on this picture, but they connect as I'm demonstrating with the cursor. They connect this way, so the elasticity of this issue is not infinite, and that increases the pressure. This stays a bit flaccid so that semen can pass during ejaculation. Now, the physiology of erection involves both physical, hormonal, and psychological elements. Once an individual is aroused, either from any source of arousal, which may be tactile from sense of touch, vision, memory, smell, and even auditory stimulus. The person gets an arousal, and that sends signals from the brain down through the nerves, which will send secondary messengers to the penis, allowing increased blood flow into the penis and reduced blood flow out of the penis. Now, all this is controlled by the hormones, which the male hormones is serum testosterone. The psychological elements, what I've just described, be part of the arousal, which may be tactile, vision, auditory. And once the psychological elements, any of these elements is affected, then this patient or this person could begin to have experience of weak erection or erection that is not satisfactory. So what are the types of erections that a male has? There are 3 types. The first is the genitally stimulated one, also referred to as reflexogenic erection. This is when the genitals, the penis, is touched, and that's where can be touched. Whatever touch causes stimulus in the penis can cause some reflexogenic erection. That doesn't really get to the brain. The signals just go all the way to the spinal cord and come back and synapse back on the penis. So the patient doesn't completely have a grasp over that. You won't say, oh, I can stop this. Centrally stimulated erection is now that is from the brain. What has the person seen? What is the person remembering? What smells is the person perceiving? What sounds are causing arousal in this patient? And this centrally stimulated or central stimulus, very different in different people. What one person sees and will cause some form of erection is different from what the other person will, what the guy will see. Also, this is also, modulated by our upbringing, modulated by our religion, modulated by our social status and the culture in which we grew up, and um, what's the cultural outlook to sexual intercourse. All this modify this psychogenic erection. In fact, even the media modifies this centrally stimulated psychogenic erection. The media would tend to, control what we perceive as being sex, what we the partners we perceive as being foxy. So the more of the media you imbibe, the more that's going to also affect what will cause a centrally stimulated erection in a patient or in a person. Now, the centrally originated erection, again, the patient doesn't have much control over this. This happens when the patient is in deep sleep, what we call the rapid eye movement sleep. And this is also more of a reflex. Hence why you find that men wake up with a stiff penis in the morning. So that's the centrally originated penis. Even when the man has not had any sexually oriented dreams, we still wake up with this centrally originated erection. Erectile dysfunction is classified into three major groups. The psychogenic, which means, there's no physical reason or no disease entity that one can hold on to and say, this is why this patient is having a poor erection. Psychogenic, basically. Organic means, yes, there's a problem. This patient has some form of illness that's affecting either the brain or it's affecting the nervous system, it's affecting the hormones, or there are problems with the cardiovascular, which is the heart and the blood vessels that will bring blood to the penis. So those are called organic. Then there's the mixed type, which involves both psychogenic and organic. Oftentimes, you don't know, oftentimes it starts with an organic cause, and then because the patient is having some poor erection, sexual activities are not satisfactory, the patient then begins to have some psychogenic causes also, because patient then begins to lose self-confidence, begins to dread having sex, starts having reasons or giving excuses to the partner why he cannot or why he cannot doesn't want to have sexual relations with the partner. A little more about the psychogenic. The psychogenic, again, is further classified into the generalized type and the situational type. And the generalized type, it could just be that this patient is unresponsive to all the sexual stimulus. And oftentimes, these ones happen right from once the patient is his sexual debut. The patient just experiences that he's not having good erectile function. Is completely, whatever arousal, whatever stimulus is sent his way, doesn't get him there. So that's the generalized unresponsive. It can be due to lack of arousal, also be age-related. As a patient gets to the age of 50, 60, I mean right from 40 though, but more pronounced for 50, 60, the hormone testosterone begins to decline. And because the hormone is declining, libido also declines, erectile function also declines. However, I mean, this can be taken care of. Sometimes patients have some form of inhibition. He's had good erections before, but he's had poor sexual sexual experiences, and so he's not looking forward to sex anymore. Or he's having some problems being intimate with his partner, and that can also be because of erectile dysfunction in this patient. What's the situational type? The three keys. This patient has erectile dysfunction. He has a weak erection, but he understands that sometimes he has very good erection, and this is related to different things. He realizes that, oh, with this partner, I have very good erection. With this partner, I don't have good erection. So you then know, okay, there's really no problem with the tubes. It's just something in the wiring. The patient is not wired towards that person. So that's partner related. Or when the patient or the person has some form of intimacy problems with his spouse. Um, I guess there are men on this group. So the lady has asked for something. You are not performing your duties financially. That could also lead to some relational problems, and then start to have some erectile dysfunction. Sometimes performance related. Person has had some poor performance in the past. The partner has not been quite understanding about it. The partner has said some very damning words to the man that affect his ego, and then the person has a vicious circle of performance anxiety, and that continues to worsen the erectile problem. Psychological stress. There's an adage that, excuse me, please. There's an adage that if your pocket is not deep, your penis should not be stiff. So, I mean, if a man is having some financial problems, he's lost his job, his landlord is asking him to move out, or, I mean, he's in between jobs, or anything of that nature, that in itself will lead to some form of can lead to some form of erectile dysfunction. Now, what are the things that puts a man at risk for psychogenic erectile dysfunction? Again, as I mentioned earlier, patient with some form of anxiety, either anxiety from intimacy, anxiety, performance anxiety, patients who are dealing with some form of depression, any patient who's had a feeling of self-inadequacy in sex, he's had cause to discuss his sexual history with his colleagues or his friends. And I mean, he feels he's falling short of what the other colleagues are doing, whether they're truthfully or erroneously just bloating their own egos by what they say they've done. But he just finds that he feels, oh man, I'm not doing what these guys are doing. How do I get better? So that in itself begins to affect the man's psyche, low self-esteem. Sometimes patients just don't know how to describe what they are feeling. And then again, stress. As I earlier mentioned, social ideas on how couples are meant to interact. I put men and women here. In some environments, sexes are different. So we use the word, we just say partners. So supposed to interact, and that can contribute to erectile dysfunction. Sometimes patients have unrealistic expectations. Some people have pornographic expectations of what sexual intercourse should be like. And so they're aiming for, they want to be a Superman and fly. And I mean, no matter how much you train, they're not going to fly anytime soon. Sometimes that happens. And then when you have people who are your role models telling you about what sex is, and they're giving you the wrong information. So all this can lead to...
Dr. Animashaun, do you want to
Yeah.
give them an example of what the wrong information might be?
Yes. Okay. Let put it this way. There are people who will say, oh, I do have sex and go 3 to 4 sessions of sexual intercourse at the go. Now, that's not true. There's something we call the latent period. After you've ejaculated, there's a period where the penis will go a bit flaccid, and it takes a little while before the patient regains his erectile function, the erection. And so somebody comes and says, wow, this night I went 4 times. I went 6 times at the go in the night, and then early in the morning I went 4 times again. I mean, if you're trying to achieve such a thing, well, it's a tall order. That's the truth. That is the normal physiology that after ejaculation, the penis is going to go flaccid. Then the patient is going to, the patient is going to take a little while before the arousal comes again, and then the patient has another erection. Now, the latency period for different patients are different. It's different, actually. So some patients will have 30 minutes to an hour, which is quite good. And some patients will even have it longer than that. I mean, physical powers are actually very different. Some people will also say, oh, I go at least 3 hours before I ejaculate. I mean, studies have shown that most men ejaculate within 3 to 8 minutes of intravaginal penetrative sexual intercourse. So the longest ever recorded in history is 45 minutes. And I'm sure that's probably a Guinness Book of Record kind of thing. So asking, so asking your patients to look towards having 1 hour, 3 hours of continuous intercourse. Even though the partner gets tired and pushes the patient off. Usually that happens. In fact, that's even the problem, usually called delayed ejaculation. And that's often the problem. The man will not have any satisfaction. The female also gets tired and thinks sex is quite boring. Okay. Now, the organic erectile dysfunction, like I mentioned earlier, these are when there are actual disease entities that are causing problems, either with the cardiovascular and neurological or hormonal or psychological or brain, things that are obviously there that need to be taken care of. So for cardiovascular, this list is not exhaustive, but I've just put it the commonest causes that we find around this environment. Cardiovascular diabetes. Diabetes is one of the commonest causes of organic erectile dysfunction in this environment. Diabetes can affect the blood vessels. Diabetes can affect the nerves. So it can actually fall both the cardiovascular and neurological. Does it mean every diabetic patient will have erectile dysfunction? No. If the patient has actually taken care of his diabetes properly and has had good sugar control over a long period of time, he's seen his endocrinologist regularly, most patients will have good satisfactory erectile function. But as a complication of diabetes, one of the complications is actually erectile dysfunction, and this can actually be very challenging to treat. Hypertension is also a common cause in this environment, affecting the blood vessels. Smoking, obesity. Now, for obesity, it's been found that even patients with organic eating from obesity, a loss of 10% body weight in itself, just with exercise, diet, and all that, and 10% body weight is lost, the erectile function, it's like you kickstart the engine again. So obesity is one of those causes. This lipidemia just means the lipids in the blood, they're they're more than they should be, and this can also be taken care of. Priapism, this is a common cause and is linked often to sickle cell disease, but not related to sickle cell disease alone. And now, let me spend a little time on this. Priapism is what is called a persistent, painful, purposeless penile erection. The patient has, or the person has erection that lasts more than 4 hours. Once erection lasts more than 4 hours, it's going to become painful. And this erection is not going to go down even when the patient has sexual intercourse and ejaculates. Now, what are the reasons, the common causes of priapism? The commonest cause in this environment is actually sickle cell disease. However, another very common cause is people who use eretogenic medications, either the non-prescription and prescription, the ones they buy at the bus stop from the ladies carrying things that they call natural herbs, those with either alcohol or non-alcoholic, and they tell you, no, it's for the back. People from my own part of the country will say, oh, fine. They drink all that and say to straighten your back. It's actually for sexual function. Anytime you have tradomedical colleagues, let me call them that, quote, tradomedical people come into town and have trade fairs, you have a lot of priapism going around. And that's because many of these drugs contain Viagra, tadalafil, crushed in those drugs at very high doses. And so when these patients take them, the erector may persist beyond 4 hours. And if this is not intervened between 4 to 8 hours, this patient may actually lose his erection permanently for life. And so it's quite distressing. Yes, we can still treat post-paraphism erectile dysfunction, but treatment is not as simple. Sickle cell disease, myocardial infarction, very important. Patients who have heart disease, it takes the heart to pump blood into the, excuse me, takes the heart to pump blood into the penis. So if the heart is not pumping well, that is a problem. Now, patients who also take drugs to help themselves and have myocardial infarction may have problems because sex in itself is a very serious physical activity, putting a lot of demand on the heart. But most all urologists will evaluate the patient's heart before beginning to stimulate erection. Patients who have diseases that affect the blood vessels. Neurological causes involve nerves to the penis. If there are injuries to the nerves, either from surgery or from radiation or from um, cancers around the pelvis, then patients with Parkinson's disease, spinal cord injured patients, all can be causes of organic erectile dysfunction. Hormonal, I mentioned earlier that as patients grow older, they have lower levels of testosterone, and this in itself can lead to. All right. So hypothyroidism, hyperthyroidism, hyperprolactinemia, these are all hormones that can lead to poor erection. Some drugs. Now, not all drugs. I've just listed a group of drugs, and even in these groups, not all drugs in these groups, and even the drugs in each group that can cause erectile dysfunction, not all these drugs, not every patient experiences it. So if a patient is on the drug, it's important the patient sees the urologist to try to determine if that is actually the cause of the erectile dysfunction. However, to say some antihypertensive, antipsychotics, antidepressants, some drugs that reduce androgens like testosterone, opiate drugs, and then histamine 2, H2 receptor antagonists like cimetidine have been known to reduce erectile function. Other drugs, non-prescription drugs, marijuana has been found to also reduce erectile libido and erectile function. Mixed organic and psychogenic is actually the commonest cause of erectile dysfunction. Right? Okay, so what can the urologist do to help? Usually we start with the clinical history. The clinical history will involve the sexual history of the patient. We want to know how long this has been. Is it partner related? Is it performance related? All those things I discussed when I was discussing the psychogenic causes of erectile dysfunction. Want to also dig deep into the patient's medical history. Is this patient a diabetic patient? I mean, you've seen all the things I've listed. This patient on any medication, has he had surgery, has he had different things that could have caused this erectile function. Then the psychosocial history, very important. What's this patient's background? When did this person get into sexual activity? What has been told this person as a child about sexual intercourse? Oh, sexual intercourse, many times as growing up, to avoid premarital sex in this environment, our parents will say, oh, don't do bad thing outside. Don't go and, your mothers will say, ishe kushe. And sometimes that in itself has a very bad, puts a bad thought in the child's head that whenever he's having sexual intercourse, whether as an adult or as a child, is a bad thing. And so that somehow is like guilt tripping the child. And that's sometimes lives on with the child. Religious background also can also affect the patient's erectile function. So what has this child been, what has this child been told in his religion? How religious is this child? And then this sexual activity is about to perform. Does it fall into what is acceptable in his religious inclination? And sometimes that in itself gives the patient, oh, I'm doing something really bad. My priest is not going to be happy, and all that in itself. But when he's done, he has the feeling of guilt, and so sometimes those are things that, so we need to look into all this, the sexual history, medical history, and social history to try to dig and determine, is this organic, psychogenic, or actually, again, like I said, commonest, it's mixed. mixed erectile dysfunction. Then you want to examine this patient. And this is where we always have some little challenges. Patients want, oh, doc, I'm having a problem down there. I need something to have a hand on. Yes, I can give you something to have a hand on. Rather, I want to know why you are having problems getting to this point. I need to examine you. And that I can do over the phone. So I need to see you in person, ask you a few questions, examine you for all these things. I look at the general state of this patient. How healthy is the patient? If the patient's not healthy, definitely everything's good. I mean, all systems are not go. So you want to look at the general state of this patient's health. You want to look at the external genitalia and the problems there. Sometimes we can find out, oh, this just by examining the genitalia, the penis, we can say, oh, this patient has had rapism in the past. We can see telltale signs and we know why he's having erectile dysfunction. Or some patients have problems, anatomical problems like what we call hypospadias. And a patient with hypospadias is having problem, or patients with Peyronie's disease. This will cause curvature and painful erection. And so some of these things we'll find on examination. Patients may have very small testes that are smaller than usual. So you start beginning to suspect, oh, this may be hormonal. This patient may not be producing as much testosterone as it should produce. You want to do a cardiovascular examination, examine the heart, the blood vessels, determine if it's hypertensive. Some patients don't even know they're hypertensive until they come in. Erectile dysfunction may be the first pointer to a much bigger problem. Patient comes in with erectile dysfunction, and the next thing you know, this patient has a heart problem. I send it to a cardiologist. I was privileged to see a patient this morning who has just came with erectile dysfunction. After evaluation and everything, I'm thinking this patient has prostate cancer and that's the cause of the problem. So you see, you need to examine the patient. Urological examination also very important. Then we do basic investigations. These investigations are going to be basic investigations. We want to do simple investigations like the patient's serum testosterone. You want to check the patient's heart with an ECG. You want to do the fasting lipid profile, fasting blood sugar. Those are just the basics we start with. They're the basics we start with. And so, yeah, those are the basics we start with. If there's nothing on the investigation, nothing on investigation, nothing on the examination and in the history that suggests an organic cause, then we can start some preliminary treatments at that point in time. However, sometimes you have to be more specific. You found that you think this patient has a cardiovascular problem, you may actually say, oh, sir, you need to go see a cardiologist who will evaluate you further. And once he's good in that direction, we can start treatment. Same thing with seeing a neurologist or seeing an endocrinologist for hormonal problem. The psychogenic ones, oftentimes we need to do what we call psychosexual counseling. Now, what is the treatment? We start with lifestyle changes. I mean, if you found something in a patient that requires a change, I mean, someone who's already going to the gym, I won't start saying, sir, you need more regular exercise. I don't want to kill the patient. He's already having regular exercise, and I won't say that. But for many of us who have a sedentary lifestyle, you want to do a lot more exercise, walking around, brisk walking, jogging, some little exercise here and there to allow the heart to pump, getting blood to all over the body, including the penis. Exercise will also help with the blood vessels, flow of blood, and all that. Exercise also helps with increasing stamina. Sex, again, like I said, is an physically exerting activity. You need to be physically fit to some extent. So exercise helps. A healthy diet, again, I talked about obesity earlier on. A healthy diet, try to reduce cholesterol, reduce salt, things that could also lead to hypertension and diabetes. Smoking is to stop smoking for patients who are smoking. You want to limit alcohol. Alcohol in itself is not known to cause erectile dysfunction. All in all, it said the little alcohol increases libido. A lot of alcohol kills the erection. Now, psychosexual therapy is very important because if the patient's psychosocial history points to certain things, then you need to address those. Patient may need to see a psychosexual therapist. If that's not available, the urologist will have to stand in gap and do the psychosexual counseling, look into the relationship, look into the sexual needs of the patient and those being met by this particular partner. And then so many a times we prefer to do this as couple counseling when the partners are involved. For those who are medication induced, you want to change medication, stop the medication culprit, and then change medication. Organic causes you treat, diabetes, hypertension, sickle cell disease, hypothyroidism you treat. And then we start with some oral medications. That's usually the baseline. Okay, so again, psychosexual counseling, you want to educate the couple, assess them. It's an important part of treatment, includes psychological approach, and has been proven to be actually very effective when you combine this with medication and pharmacotherapy and psychosexual therapy. What are the medications we use? The oral drugs are the phosphodiesterase 5 inhibitors, PDE5, and these drugs actually relax the muscles of the penis and allow of the vessels in the penis and allow increased blood flow into the penis. They do not cause an erection without sexual stimulation, and I think that's a very important point that's taken away from this. A lot of patients take this and just sit and wait for the erection to come on. No, you take this drug and you get the stimulants for arousal. Then as the arousal comes in, it's a booster. A boost makes the erection stiffer and makes the erection last longer. A few of their known drugs, sildenafil, which is Viagra, sildenafil, vaginafil, and avanafil. These are very common drugs. Many patients have used and or have used to them. Then there's the intracavernosal injection if the oral medications are not working. This patient is thought to inject this drug directly into the penis. And these ones do not need stimulus to cause arousal. Once you inject them, the penis becomes erect on its own. Prostadil, papaverine, phentolamine. This mix is just a mixture of two of them, while trimix is one that contains the three drugs together. This is also an option, and this is very effective, though quite expensive. Some of these drugs can be inserted into the urethra, which is the hole where urine comes out, and they dissolve and they also absorb and they cause erection. There are vacuum-assisted devices or vacuum erection devices which via vacuum, either manually or electronically, suck blood into the penis, and then a ring is placed at the root of the penis to stop blood from flowing out, and that also causes erection. Shockwave therapy, for those who have problems with their vessels and need revascularization, we have vascular surgery. Not too common, but still occurs. And then finally, penile implants. The shockwave therapy just uses short pulses of shock waves at low intensity directed towards the penis to improve blood flow. It causes new vascularization. That's new blood vessels are formed and blood flows into the penis. Not very popular, not very available. Some say it's still research. Very safe. May need several sessions before there's effect, and sometimes one may need to repeat it. I mentioned the vacuum erector device, the cylindrical shaped device, and it comes just put it on the penis. I'll show you a picture of it. Put it on the penis. In this case, this is a manual. You can see the patient is trying to create the vacuum by pumping. This is the penis. And then the ring will be placed at the base of the penis to maintain erection. Please, the ring must not be there for more than 30 minutes. Otherwise, that could lead to serious problems. And lastly, if all that does not work, we have what we call penile prosthesis. They're implants. This is the most sophisticated type. This is called the three-piece inflatable. It's there's a surgery to insert this into the penis. And once the patient, there's a reservoir here of fluid. Once the patient wants to have an erection, he pumps this, which is in the scrotum. This is the pump. Pumps this, and then penis becomes erect. So it's an on-the-go thing. There's also the two-piece and the semi-rigid. The semi-rigid is almost always rigid. Patient bends the penis, straightens the penis to have intercourse, and bends it back when he's done. However, this is like the most advanced of them all. This is a very not simple surgery, not very available, and the prostheses themselves or the implants themselves are pretty expensive. Pretty expensive. So those are penile prostheses. These are options that can be offered to patients who have had maybe erectile dysfunction that is not responding to any of these medications or other therapies, and then you can give this patient a penile prosthesis. Or patients who have had priapism, like I mentioned earlier, and have lost erection totally. None of the other therapies will work. So penile prosthesis is all that's available to search. So I'll conclude by saying erectile dysfunction can have negative effect on your sex life. It's difficult to feel attractive and confident or be intimate with your partner when you feel you're able to give him or her. Again, the him or her, because of other environments, able to give him or her the pleasure he deserves. It's caused by it causes a myriad, and let's all remember erectile dysfunction can be treated. Thank you very much for listening. Guess I'll have time to take some comments and questions. Thank you so much.